Mm. All right. So the time is 7:04. I think we can go ahead and start in the interest of time. The other ones will find us as we go along. So most welcome to today's CME. I believe this is possibly the fifth one we are doing. So I know for medical officers are usually very happy when when we have these CMEs. So tunawakaribisha sana. Just for the benefit of those who are new, we'll go ahead and start just with a brief introduction just to mention who we are as Quality Care, what we do, and then after that, we will dive into today's topic, which is shockable rhythms in cardiac arrest. So who is Quality Care? Quality Care is an international training center under the American Heart Association. So we train courses like basic life support, advanced cardiac life support, pediatric advanced life support. We also train trauma, which is pre-hospital trauma life support. And recently, we have also started training a course by the name of Point of Care Ultrasound Training. So apart from the CMEs, the hope is that after attending the CME, you'll actually gain some knowledge and skills, which you'll go and apply on the ground. But also as well, hopefully you consider coming to train with us as well. So for the purposes of the CME today, we have Eric Menya. He'll be taking us through the CME portion of today, the cardiac arrest algorithm for shockable rhythms. He's a senior AHA instructor, so you're in very, very good hands. For the clinical officers, I know currently you're trying to renew your licenses. So for specifically clinical officers, in order to be able to claim your CPD points, you have to come physically to us so that we can stamp your logbooks and sign. So in case you're a clinical officer, this is where we are based. We are based along Gong Road, Fifth Avenue Suites at 8th floor. So this is where we're based along Ngong Road, Fifth Avenue Suites at 8th floor. So this is Ngong Road just before Kenyatta National Hospital. So just on the roadside, very hard to get lost. But in case you do get lost, we will share. I'll share in the chat location as well as a number that you can reach us on. Now, as Quality Care, we're doing something called the Life is Why campaign. Actually, this CME series is as part of the Life is Why campaign. The Life is Why campaign is for the purpose of creating awareness when it comes to emergency care, specifically cardiac arrest and high quality CPR. Because for every minute that goes by for a patient who's in cardiac arrest without CPR, not only CPR, but high quality CPR, 7 to 10% chances of survival for this patient is gone for every minute. So, as part of the Life is Why campaign, we are doing CMEs in hospitals. In case you're working in a hospital somewhere that may benefit from these CMEs, not necessarily just high quality CPR, could be cardiac arrest, could be pediatric emergencies. I would request that you please get in touch and we'll see if we can come over and do a CME and hopefully improve outcomes for our patients. Now, as part of the Life is Why campaign, we are based in Nairobi. However, we also travel around the country to do basic life support, advanced cardiac life support trainings, specifically basic life and advanced life because it's the most popular course we have currently. So we would want to do other courses as well, but as it stands, they're not popular enough. But in case you yourself, you have a friend or a colleague or a group of friends or a group of colleagues, possibly who would want to train any of the other courses we have, then we also encourage you to get in touch as well. However, for BLS, ACLS, we'll be in Kisumu next week. Eldoret next week, Nakuru next week, Malindi as well, Mombasa, and Machakos. So in case you are in any of these counties or towns, we hope to see you there. We hope you will consider training at the very least in basic life support because heart disease is the number one killer of both men in the and women in the whole world, more than all forms of cancer combined. So it's almost a guarantee that at some point in your career, you will come across a patient who goes into cardiac arrest, and that high quality CPR that you will initiate will save this patient's life. So we hope you will consider training these courses. So BLS, ACLS, we do have a training that is starting this Thursday. We have a training which will start from 5th of June to 7th of June. In case that one is too close, we have another one in June. Um, I'll share the poster in the chat in case you're interested. But we also have the training timetable for July to September, which is currently out. So basically, I support advanced cardiac life support, of course, features the most because it's the most popular, but we also offer clinical ECG as well. So in case you work in the ED department, you work in HDU, you work in ICU, you work in the wards, you look at patient monitors a lot. Clinical ECG is super, super important. It will help you make better clinical decisions based on what you see. So this is not only for medical officers, clinical officers, nursing officers who are with the patient most of the time bedside. Important for you as well to improve your knowledge and skills. Pre-hospital trauma life support is a training we also offer for the medic who wants to work in the pre-hospital setup. So possibly you have gotten exhausted with the current state of affairs maybe in this country. Uh, you want to look for greener pastures, maybe work for Médecins Sans Frontières, possibly apply for a job at the UN, possibly become a flight doctor with AMREF or become a flight nurse with AMREF, then pre-hospital trauma life support is a basic requirement. That's also good to know. Pediatric advanced life support, for those who deal with the PEDS populations a lot, so if your primary patient is a child or an infant, it is rare for a PEDS population to actually enter cardiac arrest. But when it does happen, the difference between saving or not saving your patient's life will be gotten in the knowledge and the skills that you get in this training. So we encourage you a lot. Consider doing PALS as well if you deal with a lot of pediatric patients. This video, we were doing point of care ultrasound training. Here, we were specifically doing vascular access. You look for the vein, you look for the vein, you can't find it. Voila, just use your probe there. You can see it going in and then, oh, you have access. So we encourage you as well, point of care ultrasound training, not only for medical officers. So far we have trained MOs, NOs, CEOs and paramedics as well in POCAS. So it's more of, if you want to do it, unajisike na unakuja unafanya training. Here we were doing lung ultrasound. Here we are doing high quality CPR for soldiers in the bush. Most cardiac arrests happen outside of hospital. So it's important for everybody, not only medics, to know how to do high quality CPR. On the left, we're doing basic life support for non-medical staff, kabisa. This is a club, it's a sports club, which hosts families. A child nearly drowned, and that is what prompted that training. ACLS on the right, happening at our offices. Here, pre-hospital trauma life support. When a patient gets into an accident, more damage is actually done after the accident in moving this patient. So, if you're a fast responder, if you work with trauma patients a lot, very important to do pre-hospital trauma life support so that you can manage your patient effectively and give them better chances of survival. Yes, in addition to that, we've partnered with a number of companies. One I would want to mention is Global Ultrasound Institute. When you come for the point of care ultrasound training, certifying body will be GUSI, or rather GASI. They said GASI because ultrasound, so GASI. Yes, so as the name suggests, your certificate will be valid not only in Kenya but globally as well. So we hope that also encourages you to come and train. We also sell medical equipment, conversation for another day. Advanced clinical ECG, you've done ACLS, you feel the content isn't enough, karibu sana. Point of care ultrasound training, focus will be cardiac ultrasound, lung ultrasound, vascular access. Deadline for this class is 7th June. BLS, ACLS, we have a class starting on 5th. In case that one is too soon for you, we have one that will be going from 18th to 20th of June. Pediatric advanced life support, if you deal with the peds population, 26th to 27th June. Training of trainers course actually just ended. In case you want to become an AHA instructor, this is a course that you must do. Pre-hostel trauma life support, last week of this month, from 28th to 29th June. I would like to leave it there and say a big thank you for keeping the spirit of life is why strong. We know majority of people probably attend the CMEs for the purpose of gaining the CPD points, but we also hope that it actually makes a difference in the management of your patient, that you purposefully try and apply what it is that you're learning. In case you want to see us, we're located here at 5th Avenue Suites, 8th floor at Quality Care. Tunakukaribisha sana. We exist online at Quality Care Kenya on Facebook, on Instagram, on TikTok, and on LinkedIn. We also welcome you to check us out there. If you like what you see, please follow us. We would highly appreciate it. So thank you so much. I wouldn't want to take any more time than that. I'd like now to welcome the speaker for today, who is Eric, to take us through the cardiac arrest algorithm, specifically when it comes to shockable rhythms. However, you should note that it's better to come and train and get the information, ikiwa pamoja, not just parts of it. So I know we will cover shockable rhythms today, but possibly it would also require much more time to really cover it and go into it in depth. However, let me welcome Eric to take us through the algorithm. Thank you so much. In case of any questions, the chat box is there. Please Yes, please text us or chat to us in case you have any questions or comments. Thank you very much, Eric.
Thank you, Edgar. I hope I'm audible. All right. Good evening, guys. Welcome to this CME on shockable rhythms. So we'll just try and cover the key pointers that you need to know. We are saying when a patient goes into a cardiac arrest, the key feature is usually, thank you, Edgar. So the key feature is usually pulselessness. So when a patient is pulseless, then we say that patient is in cardiac arrest. And because there's no pulse, we want to start CPR. Once CPR is commenced, for ACLS, we really want to then quickly identify whether the patient has a shockable rhythm or they have a non-shockable rhythm. So the patient can either have a shockable rhythm or a non-shockable rhythm. And that's cardiac arrest in general. So the objectives for today are to look at the shockable rhythms. And the shockable rhythms are ventricular fibrillation and pulseless ventricular tachycardia. So VFib and pulseless VTAC. If a ventricular tachycardia has a pulse, then we manage it differently as we would tachycardia with a pulse. But when it doesn't have a pulse, then it's cardiac arrest and it becomes a shockable rhythm. So how do you manage as per AHA guidelines? We'll look at that. We will also talk about, though we won't really discuss it because of time, but one of the key things you must always do in cardiac arrest is to recognize and treat the reversible causes of cardiac arrest. And these are typically the H's and the T's. The H's and the T's. So a case scenario, a 55-year-old man, Mr. Kimani, walks into your emergency department. He is complaining of severe chest and abdominal pains. So you get them directed to the exam room, the emergency room. As they are laying on the stretcher and begin to remove their clothes for you to examine them, they become unresponsive. So just as the nurse was beginning to attach monitor leads, the patient falls back unconscious on the stretcher. So you're thinking, what next? What do I do next? So remember the BLS sequence. So you would ensure you're safe. You say SSS, CABD. That's your starting point. So your starting point is always SSS, CABD. I'm looking for the slide that outlines that. I'm not finding it. It's fine. So SSS, CABD becomes your starting point. Safety, then stimulate this patient. Mr. Kimani, call out their name. Tap both shoulders. Mr. Kimani, are you okay? No response. Immediately you know there's a problem. It's an emergency. Ring the alarm or shout for help, whichever setup you have in your workplace. Now, one of the things that you must have is you must have a code blue team or a cardiac arrest resuscitation team. If you don't have, make it a priority. Come up with one. So you activate the emergency response system and you get a bag valve mask an AED or a manual defibrillator, whichever you have in your setting. So the next thing you want to do is to start high quality CPR, because that is the priority. So SSSC. So you check for pulse and breathing, and going by what we are discussing, you find that there's no pulse. So you landmark, you expose their chest, place the heel of your dominant hand, 2 hands, and then you start your chest compressions. So as chest compressions are ongoing, when the team arrives, the priority then becomes identify the rhythm that the patient has. So you need to attach a cardiac monitor. So you continue CPR and you attach a cardiac monitor. Now, one of the things we must do is we must define what a ventricular fibrillation is. So a VFib is a situation where there's disorganized electrical activity of the heart, particularly affecting the ventricles. So different points in the ventricles start firing. So what will the ventricles do? They'll start quivering. So the ventricles start quivering instead of the nice organized contraction that you would usually have. This then leads to the loss of a palpable pulse. Okay? Ventricular tachycardia, on the other hand, is abnormal electrical signals coming from the ventricles, but possibly coming from one point or a more limited number of points in the case of polymorphic ventricular tachycardia. So you have multiple points, but not as many as you do in ventricular fibrillation. So that then means that ventricular tachycardia, whether monomorphic or polymorphic, can have a pulse. But what we are discussing today is when it doesn't have a pulse. So when the pulse rate, when the ventricles start contracting so quickly, they end up at a rate where there's not enough time for the ventricles to fill up with blood, such that each contraction results in pumping of blood into circulation. Therefore, we end up losing a pulse. Hemodynamically, why do we care? No pulse, meaning it's a non-perfusing rhythm. So cardiac output is hindered. There's no cardiac output whatsoever. We need to correct that. In terms of conduction, unless we correct the abnormal rhythm, this rhythm can deteriorate into an asystole, absence of electrical activity. A key point to note is that when it comes to ventricular fibrillation, the only treatment, ventricular fibrillation and pulseless ventricular tachycardia, the only treatment is defibrillation. So you guys know where you work. Do you have the capacity to defibrillate a patient? Do you have a manual defibrillator, or do you have, at the very least, an automated external defibrillator? For every minute that passes without defibrillation, the patient's chances of survival usually reduce by 7 to 10%. So even if you do have a manual defib on premise, if it takes you more than 5 minutes to get that manual defib to the location of the emergency, you have reduced that patient's chances of survival by almost 50%. So chances are that patient will not make it. Additionally, for every minute that passes without high quality CPR, chances of survival normally reduced by 7 to 10%. So these two things are very key in the management of your shockable rhythms. You want to prioritize high quality CPR as soon as you find that there's no pulse. And you also want to prioritize early defibrillation as soon as the manual defib or the AED checks in. So this is just an illustration of what we've just discussed. So as I said, cardiac arrest, first priority is CPR. As CPR is ongoing, attach a cardiac monitor and identify the rhythm on your monitor. Is it shockable or non-shockable? So the only shockable rhythms are ventricular fibrillation and pulseless ventricular tachycardia. So you realize that in both cases, the word ventricular is present. This is also ventricular. So in both cases, they are ventricular. Additionally, they are fast. So if you see a wide QRS rhythm that is fast and does not have a pulse, so QRS more than 0.12 seconds, and it is fast. It doesn't matter whether it is regular or irregular, okay? Because irregular would possibly mean polymorphic VTAC. Regular would likely mean monomorphic ventricular tachycardia. If you see a VTAC or you see an irregular wide QRS rhythm that is very fast, that would typically be ventricular fibrillation, chaotic. So anytime you see either and there's no pulse, know that you need to start CPR and you need to shock this patient as soon as possible. So this is an example of a monomorphic ventricular tachycardia. Monomorphic because the morphology of the QRSs are the same. They look similar. They have a similar morphology, all of them, and it is regular. So wide, regular, and fast, but there's no pulse, makes this a pulseless ventricular tachycardia. So that is a shockable rhythm. This is another shockable rhythm. This one, you can see the QRSs are wide, but they change. So this grouping of QRSs is different from this new grouping. And in between, there's like a twisting. So this is what we would call SAD, commonly caused by hypomagnesemia or drugs that prolong the QT interval. All right. So electrolyte imbalances such as hypomagnesemia are more common cause. This one as well, without a pulse, is actually pulseless ventricular tachycardia because it's ventricular in origin, it's fast, and it is pulseless. So without a palpable pulse, this is also a shockable rhythm. When you have a rhythm that looks like a child playing with their pen, okay, that would typically be chaotic or fibrillatory. So this would be ventricular fibrillation. So those are the rhythms that when they don't have a pulse, we need to defibrillate as soon as possible. So as soon as possible, defibrillate if they don't have a pulse. That's another example of ventricular fibrillation. Let me show you what else can happen. So if you find anything else, let's say you find rhythm strip number 1. You guys can see rhythm strip number 1. So you find rhythm strip number 1. The first thing you check is this QRS right here. So you can clearly see that this QRS starts here and ends somewhere there. This is about 2 small boxes. Anything that has a QRS less than 3 small boxes is said to be narrow. So less than or equal to 3 small boxes is said to be narrow. A narrow QRS indicates a supraventricular origin. So typically anything with a narrow QRS that does not have a pulse is non-shockable. You cannot shock that. Even if it's a tachycardia, but it has a narrow QRS, you cannot shock. So here, all these are non-shockable. This is non-shockable. And when it's non-shockable and there's electrical activity, we say that is pulseless electrical activity. So PEA and asystole are non-shockable. The only shockable ones are VFib and pulseless VTAC. So if I get the monomorphic VTAC without a pulse, that would be shockable. This one possibly was shocked and then converted. Wide QRS, but must be fast. So when you look at rhythm strip number 17, you can see the QRS is wide, yes, but the rate here is very slow, about 40 beats per minute. So that is not a shockable rhythm. The only shockable ones are VTAC and pulseless VTAC and ventricular fibrillation. So this is it. Child doodling, chaotic ventricular fibrillation. Some organization, but the QRSs are different in morphology. Polymorphic VTAC. No pulse, pulseless ventricular tachycardia. Okay. Rhythm strip number 26. No pulse, shockable, pulseless ventricular tachycardia. Rhythm strip number 25. No pulse, non-shockable. QRS is narrow. So now that we have discussed the shockable versus non-shockable and how to identify. Remember, while CPR is ongoing, you cannot identify the rhythm on the monitor. Your CPR will distort the ECG you get. So only assess the rhythm on the monitor after you are sure that you have stopped high quality CPR. I can see a hand is up. So Kelvin, maybe you can use the Q&A to ask the question. Use the Q&A to ask the question, and then we'll respond at the end of the discussion. All right. So how do we manage a ventricular? The only shockable ones are ventricular fibrillation. It's important to note that ventricular fibrillation and pulseless ventricular tachycardia. Everything else is non-shockable. Don't go defibrillating a PEA, okay? Or defibrillating an asystole. They are non-shockable. So the moment you attach your cardiac monitor, pause CPR, but not for more than 10 seconds, as you reassess for pulse as well. So check your rhythm, check pulse. There's no pulse, That's my rhythm. It is VFib. Then you need to follow the following steps. So shockable rhythms, that's VFib, pulseless, VTAC. As soon as you find that there's no pulse, of course, start CPR for your patient. If you find it is VFib or pulseless VTAC, give shock number 1. Resume CPR. And CPR is done for 2 minutes before you reassess the patient. As CPR is ongoing, if you had not established IV access, then you want to gain IV access. All right? Reassess after 2 minutes. Once you gain IV access, collect samples. If you find it is VFib or pulseless VTAC, give shock number 2. Resume CPR. And this is for 2 minutes. Okay? As CPR is ongoing, you want to start your medications. So you give epinephrine, 1 mg. You reassess after 2 minutes. You find it is still VFib or pulseless VTAC. You give shock number 3. Resume CPR. And as CPR is ongoing, we want to give amiodarone or lidocaine. Dosage for amio initially is 300 mg. For lidocaine is 1 to 1.5 mg per kg. Reassess after 2 minutes. Find it is VFib or pulseless VTAC. Give shock number 4. Resume CPR. And as CPR is ongoing, you want to give another dose of epinephrine, 1 mg. Reassess after 2 minutes. You find it is VFib or pulseless VTAC. Give shock number 5. Resume CPR. As it's ongoing, you want to give amio or lidocaine. If you're using amio, you are done. The number of dosages are just 2. And here you will give 150. Lidocaine will be 0.5 to 0.75. So half the initial dose. Reassess after 2 minutes. Find it is VFib or pulseless VTAC. You want to give shock number 6. Resume CPR. As CPR is ongoing, you then proceed to give your epinephrine. Now, from this point on, if you are using lidocaine, you are done with, if you are using amiodarone, you are done with amiodarone. For lidocaine, you have leeway up to 3 milligrams per kg. But for amiodarone, that means we are done with amiodarone. Once we are done with amiodarone, then all we will keep giving is epinephrine. But we will keep giving it after every 2 shocks. So if you find it is VFib or pulseless VTAC, you give shock number 7. You resume CPR, but now because you just gave epi 2 minutes ago, you will not give any drug. You'll reassess again after 2 minutes. You find that it is VFib or pulseless VTAC, you will give shock number 8. And after shock number 8, while CPR is ongoing, you can then consider giving your epinephrine. Additionally, in addition to shock epi, shock amio, shock epi, shock amio, shock epi, shock epi, shock epi, treat your H's and T's. Start looking to see if it's your hypoxia that has taken you to a cardiac arrest. Is it hypovolemia? Is it hypothermia? Is it hydrogen ions, acidosis? Is it hyperkalemia? Is it toxins? Is it thrombosis coronary, thrombosis pulmonary? Is it tamponade? Is it attention pneumothorax? So you're looking to see if any of those have taken you to a cardiac arrest and treat them, okay, as soon as possible. So you will follow that algorithm until your protocols, based on your facility, dictate that you stop. The physician asks that you stop the code, or say you guys grow too tired to continue, or you've reached a certain time frame. Most people work with 20 to 30 minutes. So it depends on your facility again. So that is the algorithm for treating shockable rhythms. Shock, epinephrine. Shock, amiodarone. Shock, epinephrine. Shock, amiodarone. Shock, epi. Shock, epi, shock, epi, shock, epi, shock, epi, as you look for and treat your H's and T's, all right, until you decide to stop the resuscitation. That is your cardiac arrest algorithm. Now, what is this shock that we keep talking about? To shock means to defibrillate. It is the same. It is defibrillation, or it is also called unsynchronized cardioversion. Now, unsynchronized cardioversion is done at the maximum energy setting for the defib you have. So if you have a monophasic, we have two different kinds of defibs. If you have a monophasic, this equates to 360 joules. If you have a biphasic defibrillator, this equates to 200 joules. So whichever defib you have, set it to maximum and go ahead and defibrillate. The purpose of defibrillation is to terminate all electrical activity. Now, in PEA, because the first question we have received is, what would happen if you shocked a PEA? Now, of course, technically, this patient is already dead, but if you shocked a PEA, for sure you would terminate all electrical activity. So even that hope that you had of resuscitating them, you've lost it, because for you to regain a palpable pulse, first you must have electrical activity. The ventricles must first depolarize before they contract. So if you terminate depolarizations, then possibly you have killed your patient, though technically they were already dead, because you will have terminated all electrical activity. Now imagine if your patient had a normal sinus rhythm, or a sinus bradycardia, or a sinus tachycardia. That means the origin of those rhythms is okay. It's just that the heart is not contracting. So what you need to sort out is what is causing the dissociation between your electrical activity and your mechanical activity. And that is what we call the H's and the T's. So rather than defibrillate a PA, look for and treat the H's and the T's. All right. I think that is that for shockable rhythms. So as I said, as a recap, first step, once you get your patient unresponsive, ensure you're safe. Stimulate, shout for help, check for pulse. No pulse, start CPR. As soon as the help arrives with a cardiac monitor, attach it. Pause CPR, but not for more than 10 seconds. Identify. Is it a VFib or a pulseless VTAC? If it is, shock as soon as possible. And from then on, it will be shock, epi. So shock, shock, epi, shock, amio, shock, epi, shock, amio, shock, epi, shock, shock, epi, shock, shock, epi, shock, shock, epi, shock, shock, epi, as you treat your H's and T's. So start looking for and treating your H's and T's as early as possible. All right. So that is that for cardiac arrest. Edgar, I don't know which approach you'd like for us to take with the questions. Do I read or do you want to go ahead and read? So feel free to share
The
your
questions. All
question.
right. Thank you very much, Eric, for that very nice presentation. I feel it was very straight to the point, which is important when it comes to cardiac arrest. So we have a question from anonymous attendee. He or she asks, what happens when you defibrillate a PA? I believe that question has been answered. So you would kill what little hope that patient had of surviving. So we never want to shock non-shockable rhythms. Second question we have is from Ian. What is the subsequent dose for epi after exhausting AMI? Yes.
So thank you, Edgar. So the dose for epinephrine remains 1 milligram. So it is 1 milligram in cardiac arrest, whether shockable or non-shockable, epi 1 mg. So it will be epi 1 mg after every 2 shocks.
All right. Last
And there's no
question.
maximum.
There's no maximum dose for epi. Yes. All right. Thank you. Thank you very much. Last question from Kevin. Kevin asks, is it possible to identify a pulseless in ventricular tachycardia by just looking at the ECG? Or yeah, I suppose he's asking if it's possible to identify if the patient doesn't have a pulse by just looking at the ECG. Is that possible?
Yeah. No, it's not. So what we must know is the ECG, even in a patient who has a pulse, the ECG just tells you the, the character of depolarization. But whether or not that depolarization is resulting in contractions can only be deduced through palpating for a pulse. So you must palpate for a carotid pulse for at least 5, not more than 10 seconds. So if I find that there's no palpable pulse and there's uh, a rhythm on the monitor that is ventricular tachy, then I know I have a pulseless ventricular tachy. So you must palpate for a pulse.
Yes, thanks so much. Yes, you must palpate for a pulse. Question from Brenda. Do we give epi IM or IV?
The epi is usually IV. And that is why we said after the first shock, if you do not already have IV access, you want to gain IV access as CPR is ongoing for the 2 minutes. So gain IV access, because if the first shock fails to work, you will give a second shock and immediately follow it with epinephrine. These drugs are given during CPR, immediately after the shock.
Yes, so thank you very much. I believe that's the last question we have for today. So I'd like to take this opportunity to thank our speaker, Eric, as always, for doing a very good job in simplifying what could be a very tough subject. So I hope we have all benefited from today's session. I would also want to take this opportunity to thank the attendees as well. Thanks so much for making the time and for trying to keep the spirit of Life is Why strong. We sincerely hope that this information will make a difference. I know in some cases, a patient goes into cardiac arrest and you just give epinephrine. You just give epinephrine. You don't know if it's shockable, if it's non-shockable. So we really hope that is going to change. There was a question which was asked a bit earlier regarding CPD points. I remember it was by Mercy. So CPD points for nurses are issued via certificates. So we'll issue certificates which will then upload to the portal, the NCK portal, and then after 5 days, the CPD points will reflect. So that's for nursing officers. For medical officers, we'll share, there's a CPD claim card. We'll share the CPD claim card. For clinical officers, I know that yeah, it's time for licensing, man. I've gotten very many visits from clinical officers. So in case that's you, this is where we are located. Please drop by and we will stamp your logbook for you so that stamp and sign so that you're able to claim those certificates. For nurses, we'll share certificates which you will upload in the NCK portal or portal yeah, NCK. For medical officers, we'll share CPD claim cards. For those of us who joined late, we hope you will consider training in our courses. We got PHTLS, we got training of trainers for those who want to become instructors under the American Heart Association. We got pediatric advanced life support training if you deal with the peds population. We have the regular basic life support, advanced cardiac life support training, management for adults. The focus for this training is primarily adults. So in case you deal with the peds population, then you'd want to do PALS. We do have a BLS ACLS starting on Thursday, which is after tomorrow. If that one is too soon for you, we got another one from 18th of June. Point of care ultrasound training, anyone can do it. Medical officers, clinical officers, nursing officers. The question is like, do you want to increase your knowledge base? Do you want to increase your scope? When people are talking about let's do an ultrasound, like, do you actually understand? So tunawakaribisha sana. Also consider doing podcasts to increase your knowledge, your skills, and also if you're looking for CPD points, you get 50 CPD points there. Clinical ECG, if you work in the ICU, if you work in the HDU, if you work in the patient wards, you look at patient monitors a lot, then clinical ECG is a must. It will help you in the management of your patient. Having said that, we say a big thank you for attending today. CPD points will start issuing CPD points on Friday. So we'll share an email which will prompt you to then get in touch via WhatsApp so that we can identify if you're a medical officer, we send you the claim card. If you're a nursing officer, we send you your certificate. If you're a clinical officer, of course, you'll have to come physically to us. Brenda, Polly, ni 5 days. Yes, it's 5 days for nurse. Is it 5 days? Yeah, I think it's 5 days. It could be sooner, but usually officials from NCK say 5 days. So at least tutapata CPD points. So thank you very much, everyone. We usually say, please share knowledge. Whatever you get from here, please share with a friend or a colleague. You say, hey, by the way, we did this. CME, they talked of shockable rhythms. Did you know the only shockable rhythms are ventricular in origin? The only ones which you can shock must have a wide QRS. And you share knowledge and you help someone and someone helps another one. And we improve emergency care here in Kenya. So we'll share emails. We'll get in touch with you. How do we know the next session? We usually post on our social media as well as our statuses. So please be on the lookout for that. We also have a group. We have a quality care group. In case you're interested, we'll share just a link to join via email. Kama uko interested, unaweza join. We usually share updates regarding emergency care, offers we have for training, as well as the CMEs as well. Yes. So thank you. Thanks so much, everyone, for joining. We hope to see you in the next one. Yes, Brenda will be sharing the link ASAP. We hope to see you again. Have a great evening. See you in the next CME. Goodbye.